We have Dean Challey from the Brooks College of Health, Dr. Maggiera, a hospitalist at St. Vincent's. We have Corey Meyer, who is a chief nursing role at Baptist Health, and Commander Oberman, who has been integral in making the work alive at Navy, and then our 4 previous presenters. So it's a chance for the next 15 minutes to continue some of the questions that were raised, and I want to start with that theme of coaching, and then we want to make certain we get back to some other themes. I believe that you had I'm sorry, at the middle table, you had a question on coaching that we didn't get to, and I don't know if you still would like to ask that. I didn't want to preclude.
I will say that I think, and I think there's room for anyone, but as a provider coaching another provider, a physician coaching another physician, or a nurse to coach another nurse, I think is really integral, because I know the challenges they're dealing with on a daily basis, and because I'm a clinician, I deal with the same challenges on a daily basis. And so be able to coach them to improve their communication. And a lot of times it's just a relationship issue, that the provider or the physician doesn't know how to form a relationship with the patient. Or maybe they're in a discordant kind of, specialty. It might be a surgeon kind of mentality in a primary care profession, and really that patient just wants a relationship with their provider, and they're not getting it. And so it's just working on that. But it's been very successful, and, so.
Okay, great, thanks. Pass the mic there. And got a panel of experts here to...
No, thank you. Lieutenant Commander Angela Powell. I'm one of the otolaryngologists at Naval Hospital. Good morning. And actually, it was touched on by my counterpart, so we must have been kind of in the same vein there anyway. But essentially, all of the EMR-related issues that we have and the fiscal constraints that we have, and in the Navy, we also have military hierarchy, and we have online training requirements, and all of these other collateral responsibilities that kind of pull us in a million different directions. And so I think this issue of communication, I'm asking of all of you, how do you juggle all of those things as providers and administrators and clinicians, and use what you have for the knowledge base for all of those years of training to communicate that effectively in a 15-minute appointment, or in your 20-minute appointment when you've got 30 patients scheduled that day. I went through the Caring Communications course, and I thought there were a lot of valuable pearls, but what I found was when I'm doing a 10-minute pre-op, it's kind of hard to use them. So I wanted to ask you all to kind of touch on that.
Anybody?
If I may, I know that the great thing about the course is there's actually, it's pragmatic, practical tool. We talk about the toolbox, and those are things we actually use. It's not just this nebulous concept. So, and every time I teach a class, it edifies me, and then I do better the next week. So then I realize that I need sustainment as well. So that's why the importance of sustainment comes in, because I am better after I teach the course. I use reflective listening. I use my SBAR. I use my pearls better each time I teach the course. And then I might go back in my old pattern because we're also rushed and stuff. But that's where sustainment in my mind, and that's why I'm so passionate about it. We have to continue to edify this. And it's great that I have the advantage of teaching it, because each time I teach it, I go back and I do better. So that's my answer as far as...
Well, at Nemours, when we went through our first round of teaching, fortunately it turned out, although I was pretty leery, we had our chair of anesthesia, who started by saying, what the hell am I going to do with this? A radiologist and an orthopedic surgeon. How can you do worse? The radiologist said at the end, one of the things she would say, so she'd have somebody call in about an x-ray, and she would tell them about the x-ray they're calling in about. Anything else I could answer for you? Comes right out of the Caring Communication. She got these incredible responses. Like, nobody had ever said that to her. An anesthesiologist doing pre-op, you got 2-3 minutes. And he would just basically say, introduce himself, this is what I'm going to do. Before we go any further, do you have any questions I could try to answer for you? And keep it to like 30, 45 seconds. Turned out it went much better, and it took no more time.
Saves me time too. If I get everything out there on the table ahead of time, it saves me a lot of going back and reinvestigating. So I do think for somebody who's seeing a patient maybe a little different than your situation, I think it does save time in the long run because you get all the issues out to start with, and the patient also does develop much more of a relationship and is much more satisfied. And I've definitely noticed a difference using the pearls versus not using them.
I think one of the things we did at UF is we printed and laminated the pearls, the acronym, on a size that you could put behind your badge, so people can sort of refer to them. But I think, as Paul said, we had the same situation where pathologists, they have lots of patients, but they are usually dead or somewhere else. My wife is a pathologist, so I can pick on pathologists. But I think I would hear, from my wife that, they get these calls from irate physicians sometimes, not necessarily patients, but you can certainly use pearls there. And so I think, whether we are using the pearls for patients or we are using for the other physicians, we are helping better the healthcare system. So I think it's an opportunity it's not just for using it could be your staff, it could be your ancillary support staff, so you can use it in several ways.
So kind of following up on that, I would like to ask Dean Challey, she has taken this work to a different venue, and as she's answering this, I want each of you to think in your own sphere of work how this could really apply. But Dr. Challey, you've taken this to your students and your faculty in the Brooks College of Health. So how was that experience, and what has happened in your arena?
Well, thank you for the opportunity to talk about it. When I sat here and listened to all the comments about caring communication, it seemed if there ever was a place where it was appropriate would be with our students. But of course, we felt it was important that we first roll it out to our faculty. There were some faculty who thought it was great. There were some faculty, I've never gotten such looks in all my life. And you all can appreciate that, I'm sure, rolling it out to very, very seasoned healthcare providers. I guess the biggest thing in the interest of time is that we compared faculty scores, their rating scores from students who had been through the course before and after they went through the course. So it was only those that went through the course, and again, it was before and after. And we found that there was a significant difference in terms of how the students reported faculty showed respect and concern. Like, wow, that's why we do this, and that's why we continue to be committed. Now, our biggest challenge is figuring out how we can roll this out to all of our 3,500 students. That still is a challenge. We have done some workshops with students, and their response is just amazing. It makes me remember why I went into teaching in the first place. The students just love this and view it as some additional tools that they think will be very helpful as they continue their careers in the health professions.
Thanks. Any questions from the floor? Keep thinking. Yeah.
Just a question for any member of the groups, any members of the group. How do you see the increasing use of technology helping or hindering communication and caring and development of the relationship between the clinician and the patient?
Great question.
Let me answer by saying that one of my professors used to say, half of what we know in medicine today is wrong. The challenge is we don't know which half. So I think, well, that can change. Technologies can change, new can come, old can go. I think the point of having that communication and the humility that what we know, half of it may be wrong, I think the communication part is not instead of that, it is in addition to that. While we have done great success and accomplishment in the technology of medicine and all of that, I think we are lagging significantly in the communication part. We are taught 4 years of medical school, everything about the human body and what we can do with it, and then in residency, but spend very little time in teaching communication and effective communication, patient-centered communication. So while your point is well taken, I think that technology has to stay in, and it certainly is wonderful to have that, but it's the relationship, the human part that we are significantly lagging.
I think it's a two-edged sword. That is, if it allows us to be in contact with patients more readily and decrease some of the barriers to getting easy answers and staying in touch and dumping data and things like that, it's great. Obviously, we all see people or have seen people who are during the visit are simply clinicians who are simply staring at the computer and inputting. That's awful. So the EMRs provide some safety, although as somebody who kind of winds up reading these charts, all it frequently is garbage. You've got all the meds and all the vital signs and no idea what the clinician was thinking. It's just unmitigated garbage. So I think it really is a two-edged sword.
I would just add one thing. I agree with everything that Paul just said, but it's important to acknowledge the 900-pound gorilla in the room, and that is that you have to get a certain amount of information put into that computer, and you've got to do your working to take care of the patient. But I mean, why not invite that technology into the relationship with the patient and just say, look, for your safety, I've just got to make sure I've got all your meds correct. Would that be okay? And just make it part of that relationship rather than using it as a barrier to that relationship. And I think it's as simple as that.
I couldn't agree more. I think there are people who are very skilled at doing that and people who could be a lot more skilled at doing that.
Question for particularly our Baptist and St. Vincent's colleagues. You heard the Navy said we can mandate this, and you heard the University of Florida said we can mandate this, and Mayo Clinic said they can mandate that because they have all employed or employed model. So I heard a chuckle. So two parts of the question. I first want to hear from Corey and from Dr. I'm sorry, Maggiera. I got to look up the pronunciation. I'm sorry. So I want to hear how that came to life in your organizations where you do not have an employed model and you do not have the ability to necessarily mandate. And what did you do to make it successful? And the flip side of that, for those of you who do have mandates, how easy was it just to have that mandate? Did it just piece of cake? So we'll start with the first one.
Well, to speak, it's been difficult for us. We've had a lot of challenges. We have managed to train most of the hospitalists and the house staff, which has been good. The house staff actually are surprisingly well trained, which I think is promising. I think in medical school they're training a lot more of this communication, which is awesome. The difficult part for us is getting buy-in from the older staff, as you may imagine. And I mean, you can all picture that, someone's been practicing for years, they don't think they need the communication skills, they think they're good at it, or the surgeons who don't actually care if they have the communication skills as long as they can cut. So we're anticipating challenges with them. Our plan to combat that is in our next session, which is tomorrow. We are involving several key administrators, key nursing supervisors, and we hope to get more buy-in from administration and then use that leverage to really encourage everybody else to participate. I think once we get more people involved, we can have that culture change, which everyone's talked about. I think that's really important. I think not only better communication with your patients, but also with your colleagues, with staff. All of that's going to lead to happier employees, happier patients, a happier place to work, like everybody said. So I'm looking forward to that next phase. You're a little further along, I think, than us.
Well, our journey began in 2010, and so it's taken us about 2 years. And in the fall of 2012, we trained 9 physician faculty members from our independent medical staff. But the support from Dr. Maples, Dr. Coble, and Dr. Rathor, we presented the program to key people in the medical staff over 2 years. We had some of the same responses that you talked about. Anesthesia said, I don't talk to my patients. Radiology, I don't talk to my patients. So we kept bringing it to different people in the medical staff. And then in the fall of last year, or summer, our CEO and our chief medical officer for the health system and myself we identified as a strategic initiative for patient safety and patient experience. And so that really, getting the buy-in from our CEO was critical. The 9 faculty members were hand-selected. One of them's in the back of the room right now. And they committed to the 40-hour training. But after that, they are volunteering their time to train our medical staff. We've gotten the support of Emergency Resource Group, which staffs our ER. They made it mandatory. And then our Baptist primary care hospitalists also made the course mandatory, which helped the initiative. So we've taught 6 classes. We've trained 115 physicians. Our CEO has taken the course. Our COO has taken the course. 3 hospital presidents. And senior leadership has also committed to taking the course. But we're only allowing a couple senior leaders in with the medical staff, since it really is a physician teaching physician course. So it's, it felt like a long journey. But the evaluations are great. I went to the medical staff leadership retreat in April, and I paired with either an instructor or a physician that's taken the course, and we presented the wows of the course to the key leaders in the medical staff. And after that, the anesthesia group that practices at Baptist Beaches has committed 100% participation. All the classes have almost, for the rest of the year, we're probably about 50% full for the next classes beginning in August. So we really are seeing the buy-in. The medical staff's even talked about considering it mandatory at some point. We do it from 4 to 8 at night so that the medical staff doesn't have to give up too much of their office time. It is a long evening for those of us that are teaching and for the medical staff that are taking it. But it's been very successful.
Great. Wes.
I'll make one more comment. I was at Mayo Clinic for 18 years and have just launched into a new career. I was actually approached by 2 private physicians asking for this work, and I did not know why until I started talking to our financial people. There's been a lot of contract and a lot of interest in generating at-risk populations for population health care. 2 of the metrics for the at-risk dollars are patient satisfaction and communication skills, and these were surgeons that approached me. So now money's on the line, and they really want to get into this work, and it's something I didn't expect. I thought I was going to have an uphill battle, and now I've got people in my office asking for this work. So just another kind of facet of that.
So, if I could just make one comment. Next week, in Jacksonville, we have a group, it's called the First Coast Nurse Leaders. It's been a group that's been around probably for about 7 or 8 years. I'm really proud of this group just because we've sat around the table for years and talked about things. And on Wednesday, all the First Coast Nurse Leaders are going to be trained in the basic communication. I thought maybe it was important to tell you all that because I don't know what will happen when they come back. You'll either hear what a terrible teacher I am, perhaps, or there may be even more people that will want this. And when you think about patient satisfaction scores and employee satisfaction scores, the physician is incredibly important, but so are some of the other team members. So anyway, Wednesday should be a lot of fun.
I think on those lines, there's a higher program for the Department of Health program through Children's Medical Services. We call it Title 21, Title 19. And this for high-risk children. And in that contract, it's a requirement for training available. It's not a requirement for the providers to train at this point in time, but training be made available to those who are going to participate in that program for both cultural, linguistic, and patient communication. So I think those sorts of things, I think there are some things in actually ACA also relating to that. So I think down the road, it may not be a choice for many of us if you want to practice medicine and want to get effective remuneration for our services.
If I may add too, that at our institution, I think it's important. It's across the entire healthcare continuum. It's not just provider-centric. There's communication across every level. So we have facilitators who we're interested, but I think it's really important. We have an OT, a PT, an audiology, allied health representative, a nurse practitioner, nurses. We now actually are expanding that to our allied health. We gave it to our senior enlisted because half of our hospital staff are actually enlisted members, and we gave it to their senior enlisted. And we also met the medical home team. We have medical home teams, and they actually are supposed to work it as a team and supposed to communicate effectively. So we've just started implementing it just for the medical home teams, and that was so favorably received that mostly by the enlisted. The enlisted asked, "I want more of this. This is great. I want to be engaged. You're allowing me to have a voice." So I think we're expanding it more than just the providers. It's at every level of the healthcare continuum.
Okay, if I could, first of all, thank the panel. Second, I'm going to have the panel take your positions as facilitators and get set up. Station 1 will be here, 2, 3, and 4. And I think you have your assignments. So I just have a couple, while you're moving up to your stations, I have a couple remarks. I want to bring us back to Dr. Leonard's presentation this morning in terms of really creating the culture of safety, the psychological safety, how are we going to create that respect. And I'm hoping you heard resonating through many of the discussions here that this is way, way, way beyond just getting patient experience. And when you look at what the Institute of Medicine asked us to do 13 years ago to really work at avoiding preventable harm, and we started here, we were supposed to end here, and we got about here at 10 years. And you ask why, and I think it's this piece of the puzzle that we really have not paid as much attention to. So we have an opportunity now to move this forward, and you have an opportunity to move this forward. In Northeast Florida, you have all the seeds that are planted, and now we have to find a way to really let them blossom and grow. So the next part of this is for you, and it's going to allow you to get a little exercise as well. We're not going to do yoga or anything like that.